morning, good afternoon, and good evening for Membening and all of our friends. So we are from Group 10, and there's Nia, Tania, and also me, Arya, as a director. And right now, I'm going to ask Dr. Nia about what is the background identification from the last case. Can you describe it, please?
In the last case, the patient has suffered a severe ischemic stroke that caused a brain hemorrhage. In other words, like bleeding inside the brain. After receiving initial treatment in the emergency department, the patient is now stable enough to be moved to the ICU.
Okay, so based on the background identification, can you elaborate more about the hazard and risks from the last case?
Okay, now let's talk about hazard and risk because even after initial stabilization, the situation is far from rest. The first one is paralysis. Some limbs are no longer functional. For example, the patient, if the left side of the brain is affected, the right arm and leg might be paralyzed. Secondly is emotional distress. The patient might be confused, scared, or unable to speak. A natural response to such trauma, this can make communication with staff very difficult. And the third is poor coordination. The stroke has likely affected the brain's control area. Even simple tasks like sitting up or swallowing could be impaired. And the next one is aphasia syndrome. This is a language disorder, so the patient may understand what we say but not be able to respond clearly. For example, they might want water but can't find the word. And the last one is brain damage. This is the root of the other symptoms and it requires constant to the assessment.
Okay, so based on the hazard and risk that you already mentioned, can you tell me who might be involved from that situation and also the task distribution from that case?
So this kind of case requires interdisciplinary teamwork. Every role is essential. So for the first role is ED charge nurse. They are the coordinator. They notify the ICU that a transfer is needed, confirm bed availability, and communicate an estimated time of arrival. For example, if the ICU has no beds, the patient can be moved so the charge nurse ensure there's space and that everyone is ready. For the next one is ED nurse and physician. So they are responsible to prepare the patient for transfer, stabilizing vitals, and reviewing medication. And the next one is ICU physician. So once in the ICU, the patient is under their care. So they lead the team, review the AD notes, and assess the current condition and begin the long-term care plan. And the last one is radiology and technician respiratory therapist. So they will do such as CT or MRI scans for the patient. And for the therapist, they will setting or oxygen delivery systems before and during transfer.
Okay, thank you, Dr. Nia, for the explanation. So now I'm going to ask senior nurse Tania, what type of tools that probably you use from the situation in the ICU?
Okay, so for the tools that use is the first one is the bed. It's where is the patient is placed and to transport the patient. The next one is the oxygen delivery system. It's a device used to provide supplemental oxygen to the patient. Next is blood pressure monitor. It's a device to monitor patient blood pressure. Next is pulse oximeter. It's a device for regulating oxygen saturation in the blood. Next is the NIH stroke scale. It's a tool to measure the severity of the stroke. And the last one is the infusion pumps. It's a device used to administer fluids or medicine through the vein.
Okay, so there's quite a lot of tools. And then for the next point is about service user. What kind of service that you provided for the patient?
So for the service user, there's the primary and the secondary. The primary is the patient itself. They need to be treated and maintained. And the secondary is the relatives of the patient. We need to give information about the patient condition to their family or maybe their friends.
So based on the service user, what kind of communication that might be used in that situation?
So the first one is the communication with the patient. Based on the experience, if the patient can communicate, we ask yes or no question like, are you feeling sick? And next, we check the understanding of the patient. We ask, where is your home and what is your name? If the patient can communicate, the patient will use hand squeeze for the response. Next is the communication with the family. We give information about current condition of the patient. Also, we will tell them about the next treatment plan. And if they feel down, we give emotional support to the family. And the communication between the healthcare staff is the emergency unit staff will give information about the situation, background, assessment about the patient, also information about the treatment that patient already had.
I see. So, thank you, nurse, for the explanation. So, based on the what your guys saying, so I think I can make a conclusion about the handover coordination. So there are 3 points that do really important. So the first one is pre-handover huddle, when you guys can do some quick brief from ED and then to check the ICU rooms, whether the bed is already completed and then the setup is already perfect. And then the second one is about handover execution, when your guys doing the job without no interruption and also no side conversation. So you must the ED nurse must ask about the vitals, meds, and also critical alert, and then the ICU nurse also needs to repeat back the instruction from the ED department. So, and then the last point is about post handover debrief. When your guys completed the handover execution, you guys need to make sure whether there are something missing orders or anything else. And then from that handover coordination, there are some assessment that we might be using in the future. So the first one is about the consciousness. So we can actually measure the consciousness of the patient with Glasgow coma scale. That is one of scale that can be used. And then the next one is respiration. We can use pulse oximeter to measure the oxygen. And then the third point is about the access. The line trips are we do really needs to know that drips is really important for the patient, especially when they're get paralyzed. And then the next is seizures. And then the fifth point is about hemodynamics. So we can measure the blood pressure and also the heart rate using tension meter for the example. And then the next point is about the electrolytes. We can assess it with the labs. So we can use tools such as CT scan or maybe MRI or anything else that can be measured. And then the last one is the DVT or deep vein thrombosis and also infection that might be happen because uh, there's some moment then that infection might be happening when patient is not in a really good shape. And then the last point that I want to tell you, so I can give some new solution for you guys. So it is a handover checklist that there's a list of pre-handover prep, equipment check, and then handover execution, and also post-handover verification. All of the step must be do perfectly and then on time because I do care about the time. So when your guys doing your job, you must be done at least not over 10 minutes. So just make sure that you guys can complete it, the new standard of operation now. So I think that's all about the meeting that we are going through. So thank you for your participation.